Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator specializing in the NICU. Today is the fourth Tuesday of September and we are rounding out our NICU Awareness Month. This month I decided to kind of keep the theme of what do we do in the NICU, what are our most common things that we're seeing. We talked about antibiotics. We talked about reasons babies are admitted to the NICU. We talked about some of our more commonly seen congenital anomalies. I don't want to say they're common congenital anomalies, just more commonly seen. And today we're going to talk about respiratory medications for NICU patients. As we all know, respiratory support is a critical aspect of our care because respiratory distress tends to be the number one diagnosis of babies admitted in the NICU. And you might be asking yourself, is that always true? But respiratory distress can apply to anyone. It's not just premature babies. It is sick term babies. It is late preterm babies needing some CPAP. It is NAS babies. It is IDM babies who have some surfactant deficiency. And of course, it is our premature babies and our micro premature babies. So respiratory distress covers almost every part of the diagnoses that we talked about when we talked about the most common reasons babies are admitted to the NICU, right? We talked about that on the second Tuesday of the month. So the medications that we use from a respiratory standpoint are wide. We're going to kind of go from the most common, the things that we probably see all the time, to maybe less common. Of course, if you're working in a level 4 with a lot of BPD kids, you're going to see more of these medications as we go on. But we're going to kind of dive into these, the ones we use most often, and see how they can help all of our patients. So let's start with surfactant. Also wanted to just start right from the beginning. MOA means mechanism of action. I almost said it wrong myself. Mechanism of action. So on every slide, it's going to have these three kind of general areas that MOA, mechanism of action, are how you give it, and then any tips or tricks. And then there might be a couple extra tips at the bottom. So also this is a mannequin head in this photo, so please don't be alarmed if that's a baby there. But surfactant is generally produced starting around 24 weeks. Every baby's going to be different. We don't have a perfect one size fits all. Surfactant is produced more and more as the baby gestates within the womb, intrauterine. When the baby comes out, they don't have enough surfactant. That causes increased surface tension. It's kind of like as if you're trying to blow up a balloon and it can't blow up because there's just no lubricant in there. So surfactant is this lubricant that helps the alveoli open and close. So it prevents collapse and it aids in proper lung expansion. You can also have lack of surfactant in IDM babies because insulin inactivates surfactant. So remember, in IDM babies, the moms have this like robust amount of insulin going. It goes over to the babies, it's in the babies, and then all of a sudden, we're in this place where the surfactant has been diminished. So they're less. So they're more likely, not only are they big, and maybe they've got these lungs that aren't quite ready, but they don't have enough surfactant. So this is most commonly administered, obviously, in our preterm infants. I was seeing some fun topics being talked about both at the NAN conference, the Delphi conference that's going on this week, and there's another conference coming up in December called Hot Topics in Neonatology, where they're talking about surfactant use outside of that first kind of 3 days. So lots of research going on there. We give surfactant via the ET tube or intratracheally, or maybe you are part of a facility that does LISA or Ensure or the new SALSA, or there's MIST trials going on. The MIST trials I hear are kind of the least effective right now, but that doesn't mean that we're not going to continue to improve on it. The LISA method is less invasive surfactant administration. Obviously, I know that one the easiest because that's my name. SALSA is using it through using a LMA, so supra, so it's going just in the back. So you're not actually visualizing the vocal cords. So with the LISA method, they are visualizing the vocal cords, they're going over the glottis, and then they are seeing it just going with a smaller tube, like either a feeding tube or an umbilical line, inserting surfactant coming out. With the SALSA, it's supraglottal, so it's above the glottis, so just kind of the difference there. So watch for dramatic changes in babies that have surfactant and it goes well. You could see a big change in your improvement in oxygenation. You may need to make changes to your ventilator quickly. So be mindful of that as your baby is doing better. So of course we have our old friend caffeine. Caffeine is a respiratory stimulant, right? Caffeine tells the brain to remind the lungs to breathe. That's kind of my parent statement. The elevator speech I have about caffeine, it is a neurological stimulant. It works on the respiratory system via a series of neurons that connect together and help the respiratory drive. So it uses those as adenosine receptors and helps the baby breathe. Caffeine is not directly going into the lungs. It's really important. It's all about the respiratory drive. So I've heard caffeine described as, oh, it's a pulmonary stimulant. Well, really, it's a respiratory stimulant, the respiratory center of the brain. Caffeine can be given lots of different ways, orally, via a feeding tube, IV. It is actually the same medication, whether it's given IV or orally, interestingly enough. But make sure you always know how you're giving your meds. This can cause tachycardia, so the standard doses are rising. When I started, it was normal to give 5 to 10, but we pretty much focused on 5, then 7.5. Now 10 is becoming the most common dosing, with 20 milligrams per kilogram per day still being part of kind of that normal upper end of normal dosing. So lots more information coming up about caffeine. I also saw that's going to be talked about at the Hot Topics. INO is inhaled nitric oxide. This is a pulmonary vasodilator. I did a big whole thing on PPHN, explaining PPHN, what's happening with those tight, smooth muscles of the pulmonary vessels. So what this is doing is saying like, hey, let's relax. So INO directly goes into the lungs. It is piped into your ventilator or wherever it needs to be. It can be used in with cannula, CPAP, in non-invasive ventilation, etc. Most of the time we're seeing it with our invasive ventilation when our babies are on a lot of oxygen and still not oxygenating well. So yes, administered via the inhaled route. The one thing I want to say about INO that's mentioned here is that this gradual wean is not a joke. So INO is ordered in parts per million ppms, typically 5 to 10 ppm, 5 to 20. So let's say you're on 20 and it's time to wean. So you might get weaning orders that say wean, every hour as tolerated, watch for increasing oxygen requirements and decreased oxygen saturations. So going from 20 to 15, 15 to 10, 10 to 5, usually is pretty standard, but going from 5 off can be the hardest part. So you'll go 5, then you start going by 1s to 4, to 3, to 2, to 1, to 3, to 2, to 1. It's like this little bouncing. And those babies hold on to that little bit that they're getting just to help with this pulmonary vasodilation by relaxing the smooth muscles of the pulmonary vessels. So remember, this is going right onto those pulmonary vessels within the baby. I think it's really important to kind of remember where it is affecting them. We're going to talk about another medication and how it helps with PPHN as well. But first, let's talk about our racemic epi and ET tube epi. So these are medications that are used for respiratory, and I want to make sure we point out that we all know that epinephrine can be used in a code for babies that are getting low heart rate, chest compressions, right? Heart rate less than 60, you've been getting chest compressions, it's time to give epinephrine. This is different. This use of epinephrine is different. So racemic epi is that nebulized epinephrine that's given to reduce airway swelling caused by vasoconstriction. It can be used for bronchospasms or stridor after extubation. Primarily that's what I've seen it for, especially if we've failed extubation previously and the baby's had stridor in previous extubations. We might begin an extubation with that, or the baby gets extubated, we're hearing the stridor, we go ahead and pull the racemic epi. ET tube epi is given for one of two reasons. Number one is that code, right? What's the ET tube dose of epinephrine? 1 ml per kilo, right? Given via the ET tube, bagged in, no flush. But for pulmonary bleeds, which is a different use, now your baby could be coding during a pulmonary bleed, but they may not be. It is given for vasoconstriction and increasing cardiac output. So we're trying to get those vessels to clamp. We're like, hey, calm down, and we're going to get you in there and so that the blood vessels stop bleeding. So if you give ET tube epinephrine for a pulmonary bleed, that is kind of outside this code aspect. And so it's kind of ordered differently. The doses is going to be different, and the way you document it would be different outside of a code. So make sure that your kind of documentation for that is going to look different. Albuterol. So albuterol is probably the most common kind of inhaled medication that we give in the NICU, whether that's via metered dose inhaler that goes on within your ventilator tubing or a nebulizer. It's a beta agonist. It relaxes the smooth muscles of the airways. It should be used cautiously in babies with tachycardia because it can cause that, so you want to be very mindful of that. As I mentioned at the NAN conference, if you did not see my recap, I went to a BPD lecture where they were really talking about the different inhalers, and some of them I had never heard of. So maybe you're using other inhalers outside of that in your NICU, but albuterol is going to be the most common, kind of our first line of defense for babies that maybe are starting to develop chronic lung disease or bronchopulmonary dysplasia, or on high levels of oxygen and having some of this kind of clamping down. So this might be a reason that we would use that to relax those smooth muscles of the airway. As sneak peeked, sildenafil. This is another medication used specifically for pulmonary hypertension, PPHN, and it is all about relaxing those pulmonary blood vessels, but this is given systemically. So you can give it orally, the NG, or intravenously, whereas INO is given directly into the respiratory system via that piped in gas that goes into your ventilator tubing. So sildenafil or Viagra is given to relax these pulmonary blood flow, to make it easier for the blood to flow through there. Remember, with pulmonary hypertension, it's like a circuit where there is a blockage in one of the circuits. So, or if your drain is clogged, right? We're trying to say, hey, let's relax a little bit so that more blood can get through this area. So that's what's going on with sildenafil in regards to pulmonary hypertension and helping babies breathe easier. I remember when we first started using this, remember I've been a NICU nurse for 20 years. Some of these things we were not doing 20 years ago. It seemed wild and crazy, and now it just seems like kind of an everyday part of it. So diuretics, again, there are many. Furosemide or Lasix tends to be one of the first ones that we use. And then over time, you may end up something like chlorothiazide or Diuril for a more long-term diuretic for your babies with their lungs, to help their lungs specifically. Remember, if there is fluid on the lungs, or the lungs have kind of this full balkiness to them, they are not going to exchange gas as well. You can have a backup of fluid onto your lungs from having a PDA. That's a contributor to kind of this pulmonary edema, which could contribute to heart failure. So we give them diuretics such as furosemide to get rid of that excess fluid. It can be given orally, NG, intravenously. Remember to watch for your electrolytes, watch your urine output, be weighing those diapers, doing weight checks, and watching your urine output. It's also important to know that chronic administration of furosemide can be a risk factor for fractures. So essentially we see increased excretion of calcium. It's as if the furosemide is leaching the calcium right out of the bones and just making them weaker. So if we're at a place where we are giving Lasix for pulmonary edema, for kind of this PDA that's leaking fluids back onto our lungs, poor oxygenation, the baby's also probably a little bit older, and maybe they've been on TPN for a prolonged time. TPN also makes it very risky for your bones. It can cause metabolic bone disease, lack of calcium in their diet. Again, if they're not growing, remember, linear growth is lung growth, is bone growth. If we just focus on weight, we're never really going to understand how the baby's growing. So we need to look at all of those factors. So you've got all these contributors, and then we're like, oh, we should start Lasix. So it's just something to think about and to consider when you're doing it. Do we need to put up a, my bones are fragile sign? Do we need to be watching our alk phos levels a little bit closer? Do we need to be changing our supplementation and adding in some mag phos or something? So things to think about in addition to giving these medications. So steroids, the most common ones we see in the NICU, most likely are hydrocortisone or dexamethasone. So mechanism of action, they reduce inflammation of the airways, decreasing the need for prolonged ventilation, improve lung function. Dexamethasone is a little stronger. That's what we used in my little baby career at the beginning. And also can be using hydrocortisone. These meds are usually given on a burst with a taper So you might give a 0.2 BID for a day, 0.1 BID for a day, 0.1 once a day, some sort of tapering so that we can wean the baby off of it. These are also the babies that you hear in roid rage because it can make them very feisty. But I love a feisty baby, so nothing wrong with that. You really have to use this in caution. Any kind of steroids in babies that are at risk for gastric bleeds, even neck, or bleeding in general. I've seen steroids not be given to babies that have grade 4 bleeds, especially at the beginning, but more over time, that's something that they will do. And it also can increase the risk for infection because it's an immunosuppressant. So lots to think about. I think steroids are given now almost with a long conversation with parents on the pros and cons. We know way more about it and their neurodevelopmental outcomes than we did when I started. So just something to really consider when steroids are going to be started is, have we made sure we've checked all the boxes, made sure that this is a safe place for the baby at this time? Do we need to wait a little bit longer? Do we need to see what's going on with our infection protocol? Do we need to see if there's other things that we can do in the meantime, decrease our total fluids, change our vent settings, etc.? But if we need to give steroids, they are there and available for us. Education for parents includes to explain why. Why are we giving them? Are we reducing inflammation? Are we trying to prevent apnea? Are we trying to get the baby to pee more so we reduce edema? Are we trying to help open little airways that weren't open before? Are we trying to lubricate the lungs? What is the reason why? We need to explain to them, like, some of these meds we're going to give once or twice. Some the baby could be on for 10 days in a row. Some they may go home on, right? Maybe albuterol, the baby's going to go home on albuterol. Maybe they're going to go, if it's a chronic BPD kid, they could go home on medications, even including sildenafil. So there are other medications that they could go home on. And some will stop when the baby's in the NICU. Obviously, we don't send a baby home on caffeine. We don't send a baby home on surfactant. I don't think we send babies home on steroids, but it's entirely possible that BPD babies do. Those are not as big of my area of expertise. So in the NICU, remember, these respiratory medications play a crucial role, but they are part of a complex need of the premature and critically ill infants. Caffeine for prematurity and surfactant seem easy, right? We're going to do these things. I have seen too much caffeine be given to a baby, and the baby had pretty profound tachycardia. Another flashback for you, we used to check caffeine levels every Sunday. We don't do that practice anymore. We can check a caffeine level if you feel the baby is getting a normal dose, but maybe having some side effects such as jitteriness or tachycardia, but we're not so much into the bloodletting as we used to be. Our job is to monitor the side effects, to make sure we've weighed the pros and cons, to educate our parents. Understanding them is going to help them feel more empowered to ask questions, to anticipate what is going to come next for their baby, and to prepare for discharge. And overall, we're going to be really supporting the NICU babies on their journey towards health. So thank you for joining me on this respiratory medication review. I hope you learn something. Feel free to leave a comment. If you have any questions, you can also email me or go find me on Instagram. My handle is the same, @_Houston we have a little play on my last name there. So go find me, send me a DM, and we can chat about anything you have. And I will see you in October.